So by way of introduction, globally, around 2.4 million newborns died in 2019. I know this has been updated. I think currently it's 2 million or 1.8. And around 1 million deaths occur on the day of birth. And around 24% of these deaths are due to birth asphyxia. We also know that birth asphyxia can lead to long-term complications such as neurodevelopmental defects and motor disorders later in life. And caring for children with neurodevelopmental defects out of birth asphyxia is very is a very hard work. And some of the parents who were interviewed in Uganda said it is imprisoning and impoverishing. So that, makes birth asphyxia a very big problem. Now, in Uganda, we have had a lot of decline in the child mortality, the blue line, and the infant mortality, which is the orange line. However, we've had barely no decline in the neonatal mortality. As you see, right now, the UN estimates it at 19 per 1,000 19 deaths per 1,000 live births. But actually, the newest demographic health survey of Uganda put it at 22. So from 27 to 22. So there's been a lot of stagnation in that area. And if you look at my right, the major cause of neonatal mortality countrywide is 29%. Yes, so further, when you look at the cause of perinatal mortality are deaths that it includes stillbirths and early neonatal deaths. Those are deaths within the first 7 days of life or deaths at birth. We see that in Uganda, our maternal perinatal death surveillance report put it at 60% of all perinatal deaths. So it's really a very, very big contributor to both, immediate death at birth and also neonatal mortality. So the rationale for my study was that the burden of birth asphyxia was not well documented. We know the contribution of birth asphyxia to neonatal mortality, but no one had really quantified or looked at the burden or how often birth asphyxia occurs generally. And also we looked at the context-specific factors in a special population of a post-conflict setting in Northern Uganda. And also we wanted to see what are the social demographic characteristics and the role of infections in birth asphyxia. We also needed to look at the intrapartum care that is given to mothers when they come to give birth in relation to preventing birth asphyxia. So the main aim was to describe the prevalence of birth asphyxia and identify the associated factors and intrapartum care practices of midwives in Northern Uganda. So specifically, we looked at prevalence and factors associated with birth asphyxia at 2 referral hospitals in Northern Uganda, and we also looked at the fetal heart rate monitoring practices of midwives in the 2 hospitals. So this is a conceptual framework that has all the studies that were involved in the PhD studies, but we're only going to look at study 1 and study 2. And that's what we are going to look at. So this is the setting. So the study was located in Northern Uganda. It's called the Acholi region. And this is just a map of Gulu district where these studies were based. We have the 2 hospitals, St. Mary's Hospital, Acho, and Gulu Regional Referral Hospital. They are close to each other. I think they are around 3 kilometers apart. They are all in the city. and they are really the main referral hospitals. However, Gulu Regional Referral Hospital is a public hospital which mainly offers, can I say, mainly free services to mothers and newborns. And then St. Mary's Lacho is a faith-based hospital where the services are subsidized, but the mothers have to pay for it. And here in the table, I just showed comparison of Acholi region versus Uganda, some of the indicators. So in terms of cesarean section rates, they have a low rate, they have a higher rate of facility births, equal rate of antenatal attendance, but the neonatal mortality rate is a bit higher than the national average. So for objective one, which looked at prevalence and factors associated with birth asphyxia, we did a cross-sectional study of all women who came to the study sites in established labor. We excluded mothers with preterm labor, intrauterine fetal death, and those who had stillbirths or multiple births or critically ill mothers. We recruited 2,930 participants consecutively, and we took off some blood samples to test for some of the infections that we anticipated could have a relationship with birth asphyxia, such as malaria and syphilis. We also tracked the HIV results for the mothers. That wasn't done by the study, but it's a routine test. We looked at the mother's complete blood count to look at the white blood cell count at admission. And then at birth, we did the APGAR scoring for the babies at both 1 minute and 5 minutes. And this is the kind of chart that we use to do the scoring. And also we used a questionnaire in the postpartum period to get information about the social demographic characteristics of the mothers. Then for objective two, where we looked at the practices of the midwives regarding fetal heart rate monitoring, we did an explanatory sequential mixed method study, which was mainly quantitative with a mix of qualitative, and we combined the findings at interpretation. So we had 251 record reviews, 42 observations of women in labor, and 11 in-depth interviews and 2 focus group discussions. So that was the mix of the study data collection. We used checklists to observe and review maternity records. And then we also interviewed the health workers using interview guides and focus group discussion guides. And then the analysis, we did descriptive statistics for the record and observations. And then we did content analysis for the qualitative data. This is a picture of me with my research assistant and my supervisor, Professor Claudia, at one of the health facilities. Yes, sorry about this. This shouldn't be there. So in terms of ethical considerations, this proposal was approved by the School of Health Sciences at Makerere University. And then we also got Uganda National Council of Science and Technology ethic approval. We had written informed consent sought from all the participants, who are mainly the health workers. And then we also sought consent from mothers. We did verbal consenting at the beginning when they came in, to take off their blood, to check for infections. And at the end, we did a full written consent when we were administering the questionnaire. Then we also requested for permission to audio record the interviews with health workers. Yes, so I want to tell you about the findings of the study. So these are general demographic characteristics. In this setting, we had many mothers who were less than 20 years. Around 24.7%, they were teenage mothers. And of course, majority were lying between 20 to 34 years, which is expected. The percentage of 24.7% of teenage mothers is around the same as for the national average. And then majority of them had very low education status, primary level. That means they've had around 7 years of formal education, and majority were not employed. They were mainly stay-home mothers. In terms of the newborns that we assessed for APGAR, most of them had a normal birth weight. We had a 16.4% cesarean birth rate, and we only had 1.6% who were born by assisted vaginal delivery, which is mainly the vacuum extraction. So in terms of prevalence, I just showed the two different APGAR scores at 1 minute. So 16.3% of babies had an APGAR score less than 7 at 1 minute. But at 5 minutes, which is what we took for our prevalence, it was 5.3%. So when we look at associations of demographic characteristics with birth asphyxia, we did a multivariable logistic regression, and we included factors which had a p-value of 0.2 in that model. And so these are the only the factors that had shown some association at the initial regression. So we see that maternal age less than 19 was more like for those women with who are teenagers were more likely to have babies with birth asphyxia, and nearly twice likely. And then we see that those who are employed were less likely to have newborns with birth asphyxia. We also see that mothers who had syphilis were more likely to have newborns with birth asphyxia, and those with a high white blood cell count. So when we look at the intrapartum and newborn factors and their association with birth asphyxia, most of these were really associated with birth asphyxia. And this was not surprising because we know that most of these complications during labor and childbirth end up leading to poor outcomes in the newborn. So mothers who had been referred, mothers who had labor going beyond 18 hours, mothers with obstructed labor, and those who had induction or augmentation of their labor were more likely to have newborns with birth asphyxia. But we see obstructed labor had like the highest odds, around 3.4 times more likely, and then also having a malpresentation, a malposition, had a three times odds of having a baby with birth asphyxia. And then when we look at the mode of birth, I think this is also really self-explanatory. Assisted vaginal birth had a very high odds of having a newborn with birth asphyxia. Yes, so in terms of sex of the newborn, females were less likely to have birth asphyxia than male newborns. And then the babies who were less than 2.5 kilograms were more likely to have birth asphyxia. This is also a bit expected. So in conclusion, we saw that the prevalence of birth asphyxia was 5.3, and we had a very long list of associated factors. But I just want to highlight that we found birth asphyxia more likely to happen in adolescent mothers, women, mothers who had syphilis infection at the moment, at the time of labor, and those who had a white blood cell count, while the rest were really expected. Yeah, this is the paper. You can look out for it. Yes, then let me talk about the fetal heart rate monitoring practices of midwives. These were the characteristics of mothers whose records were reviewed. Still, we had actually in the records, we had 31% of mothers being under 20 years. I don't know why this was different from the other study. And then most of them had come in established labor at admission. Around 75.6% came in established labor. And this shows that the most mothers don't actually come earlier to the hospital. They wait until labor is established. Now, when we look at the shift when the mothers were admitted, majority were admitted during the night shifts, 46%. Then for the newborns in the record review, I think majority also, we can see that the average, the mean birth weight was normal, 3,000 grams. And the female to male ratio is really low in Uganda. The males were 50.6%, which is nearly equal to the females. And then for the APGA scores, we had around 3% of babies with who are stillbirths with 0 APGA score, and a similar number of those with birth asphyxia scores of 1 to 6. So when we look at admission, I am presenting both the record and the observations, because the aim of this study was for us to see how the monitoring is done, and the observation was really to confirm or to correlate with what we saw in the record. So we wanted to know whether it's true that what is written is what is actually done. So when we look at use of the pattograph in Uganda, we use the pattograph for monitoring of labor. We see that this was, more documented in the observations than in the records that we reviewed. However, when we look at auscultation of the fetal heart rate, it's nearly, equal to those which were recorded and those which were observed, similar to the vaginal exam. And in the abdominal exam, it's especially looking at contractions. Very few of these were recorded. And now when it comes to the blood pressure, it was it was recorded more than what we observed. And then for urine, again, we had more records than what we observed being done. Then when it comes to monitoring of the first stage of labor, this is really what was the most important thing. We found that fetal heart rate had been recorded at least once or observed at least once in 68% of mothers, although it was recorded in higher numbers, 76.8%. But when it comes to monitoring every 30 minutes, which is what our guidelines say, we observed around only 3.8% of mothers being checked every 30 minutes, yet the records tell us it's 59%. Again, also in the abdominal exam during the first stage of labor, this was less done as we observed compared to what was written. And so we saw a discrepancy between what was observed and what was recorded in the files that we reviewed. And then in the second stage of labor, fetal heart rate was monitored only in 3.2%. When we checked the records, although on observation of the 42 mothers we observed, we didn't see anyone having their heart rate checked in the second stage of labor. Yes, so these are the key things that we felt there was really very big discrepancies. Yeah, so from the qualitative findings, we wanted to understand what was the reason for what we saw. And the first one was the dilemma of knowing and not being able to perform fetal heart rate monitoring. And under this, we had practice of fetal heart rate monitoring and the consequences of failure to monitor. I will give you a few quotes to explain what we meant by those sub-themes. And then the second theme was barriers to fetal heart rate monitoring. And these included shortage of staff, inadequate resources and equipment, barriers to documentation, some institutional barriers which were environmental, and then the negative perception of women towards fetal heart rate monitoring. So on the practice of fetal monitoring, one of the midwives said, but for fetal heart, it should be done half hourly, but sometimes sincerely, it may not be possible for a mother to be called in for checking every 30 minutes. In this hospital, most mothers, when they are in labor, they are allowed to walk outside in the compound to be with their family members. And this is partly because there are not enough beds for the first stage of labor, but also because women, don't want to be on the bed all the time, which is really good. But now this becomes also a bit of a barrier that sometimes you're not able to call the mother in for the checkup. And then we had one of the midwives in the focus group discussion telling us that actually when you don't monitor a mother, you yourself, when something happens, you are psychologically traumatized seriously. So although sometimes it was beyond their ability to monitor, this would traumatize them when something bad happens to the mother or the newborn. Then when it comes to the barriers, we talked about equipment. In this hospital, they were using fetoscopes largely. And, one of the midwives said that those fetoscopes get legs, they disappear. And that was one of the barrier to appropriate fetal monitoring. And then for staff shortage, you're supposed to manage all these units. So at times when there is a very serious case in postnatal, you're there and you leave mothers in labor. And most times you have two midwives working both in labor ward, which has 6 beds, and the postnatal ward, which has so many mothers. So that was a big barrier. But also the women did not want to be checked very often because the peanut fetoscope is a bit uncomfortable for them. So sometimes they would not accept to come back for checkup. Yeah, so in conclusion, from this objective, we found that the actual practice of fetal heart rate monitoring was suboptimal when you compare to the national and international guidelines. A quarter of the women were not monitored in the first stage of labor, and no monitoring was being done in second stage of labor. We also saw that some of the barriers included shortage of staff and devices, institutional and documentation challenges, and mothers' lack of awareness of the importance of monitoring. Yes, so this was also published in this paper. And so in terms of discussion, we found a higher prevalence of birth asphyxia compared to what had been earlier found out in a hospital in central Uganda, which was a national referral hospital. So we would have expected a higher rate of birth asphyxia in a national referral hospital, but we attribute this higher percentage to maybe the conflict situation and the rural setting where transportation of women with complications is harder. Although this prevalence was higher than the general average in the East African region, which is at 18%. We think this could be because we excluded preterms who have a higher chance of asphyxia, multiple birth, and critically ill mothers. But from the literature, we also see that there are a few countries in East Africa which have very high prevalences of asphyxia, like Ethiopia. If you've read some papers from there, it has very high rates. And then the adolescent mothers, we found that that was really a big risk factor, which had not yet been, shown in most of our countries as a risk factor. And then the elevated white blood cell count was also a high risk factor, although we know that in pregnancy, the white blood cell count is generally elevated, but I think we had not really thought that that was a risk factor for poor newborn outcomes. Yeah, the other thing was syphilis. In our country, all mothers, when they come for antenatal, they are checked for syphilis. And in this study, you saw that nearly all mothers attended antenatal. But we don't know, probably it's very important for us to keep checking the syphilis until the mother comes for labor, because this is done only once when the mother starts her antenatal visits, and it's not repeated. Maybe these mothers get repeat syphilis, or they don't recover when they are treated. I don't know, but this was really a big factor towards birth asphyxia. Then the obstetric risk factors and complications are strong predictors, and these are well described. And I think many preventive strategies are in place, although I think they are not adequate. And then we found that the fetal heart rate monitoring practices were suboptimal due to some health challenges. These have been observed in other studies in Uganda, but we also know that this is a really big challenge, which probably needs to be tackled in order to improve the outcomes of the newborns. So in terms of recommendations, yeah, we recommended regular monitoring to be prioritized, especially for mothers with obstetric risk factors, as we saw, and then for adolescent mothers, and also the need for adequate monitoring devices to remove that barrier to monitoring of fetal heart rate. And then also there's need for more staff in terms of policy for labor wards, because the workload is high, and essential supplies and equipment for women to be monitored and cared for appropriately. We also recommend a larger study to look at factors associated with birth asphyxia, maybe in terms of a cohort study, and also looking into further research for low-cost interventions to prevent birth asphyxia before this baby is born. So I wish to acknowledge, of course, the team of researchers who supported me. And I want to thank the University of Michigan for this opportunity to present my work. And yeah, my funding was from the Swedish Embassy and the Karolinska Institute. So I want to say thank you to them and Macquarie University. And yes, I want to thank you so much for listening to me, and welcome questions. So I hand over back to you, Michelle.
Thank you so much, Liz, for a wonderful presentation. And thank you for sharing the publications along the way. Both of the publications that were shared are open access, so I did put the links to those in the chat. So feel free to take a look at those for a few more details about the study and the two objectives. So we would welcome questions and conversation now. You can feel free to use the chat for questions, or raise your hand or unmute yourself to ask a question directly to Liz. While individuals are thinking about questions, I actually have a question to get us started, if that's okay. And I guess it's more of a conversation point, actually, Liz. So I was interested in the findings about adolescents and the higher rates of birth asphyxia for them, and just wondered if you could talk a little bit about support for adolescents, both in family planning and maybe contraception, and then when they are pregnant. I know in some of my work with colleagues that their adolescents have sometimes been reluctant to seek contraception or family planning because of some stigma. And just kind of thinking about the social dynamics of that, if there are any barriers or potentially opportunities, I guess, to address that in Uganda.
Thank you so much. Yeah, I think one of the things that lacks a bit of focus is the care for adolescents when they are pregnant. I should say for contraception, there have been efforts to start adolescent-friendly clinics for sexual and reproductive health. So there are a few spaces where they can go to for contraception, for some reproductive health issues. But when an adolescent comes pregnant, she takes the normal path with everyone else, both from antenatal until the labor ward. And there's a bit of, I think, a negative perception towards a pregnant adolescent and some bit of stigma, even among the health workers. But also you find that even the family is not supportive, depending on whether this adolescent was maybe married or got pregnant along the way or during school. So I think this is a gap that we have. And because adolescents don't feel very comfortable in the general spaces where other women are seeking care, I don't know whether that could affect how they make decisions about their pregnancy and when to give birth. But I'm also thinking it may be also linked to the lack of employment or lack of disposable income at that age, that they are not able to come quickly to hospital in case of a complication. Also lack of maybe knowledge about what to do when something happens. So there are so many, I think, theories about why adolescents could be more likely to have newborns with birth asphyxia, but also to do with their growth and development. They are more likely to have obstructed labor and maybe prolonged labor. So I think it's a very complex thing that maybe could need further research. Yeah.
Thank you, Liz. Yeah, I think globally it's a challenging age group when we think about all of the different challenges, right? Social, accessibility, financial, and how to ensure that services are tailored to that time frame.
Yeah.
Any questions from our audience? Again, this is intended to be a little more informal, so you can feel free to raise your hand or unmute, as well as use the written chat.
Michelle, should I stop sharing or?
That might be helpful, actually,
Okay.
Liz. I do see
Okay.
that a question just came into the chat too, but this way we can see people if they want to unmute. So the question in the chat says, "Thank you for the passionate presentation. I might have missed it, but how do expectant mothers in Uganda receive prenatal care during their pregnancy? In your opinion, to what extent is prenatal care effective in reducing neonatal asphyxia in Uganda?"
Yeah, thank you so much for that question. Antenatal care in Uganda is largely a free service. Mothers don't have to pay for it if they come to a public facility. Now, in terms of access, the 97% I showed was for mothers who attend at least once. But we see that those who come, for example, 4 times are around 56%. So it reduces depending on the number of times mothers are coming. And when mothers come, I think the package is really rich. They receive a checkup. They receive prophylactic treatment to malaria. They will be checked for HIV and syphilis and treated if they have, for example, they would start on antiretroviral therapy if they are HIV positive, and they will have treatment for syphilis if they have it. So the package per se for antenatal would really contribute towards reducing any neonatal problems. Some of the challenges probably are that some mothers come once or twice to book and be sure that they will have a place to deliver. but maybe not, not to attend the antenatal. Also, some mothers would be given, for example, iron supplementation, calcium supplementation that they might not take. So I think a little bit about quality of the care that is received it might be lacking in that sense. But I think right now the policy for antenatal is really good in Uganda, and we are really looking at all areas, including giving magnesium sulfate for neuroprotection. If a mother has had recurrent preterm births, taking care of women who have had hypertension. So the package is available, it is free. So the question would be more about access, more about uptake, and more about whether adherence to these, maybe the prophylaxis is done by the mothers in the community. Yeah. Mm. The other thing maybe I should mention is about birth preparedness, which is also, like done during antenatal visits. But some mothers would have the checklist of everything they have to prepare, but they are also constrained, if you get maybe another problem, then you end up using the money which you're supposed to use to go to hospital. So some of the challenges are about transport, they're about the cost of extra care when there are problems or complications in labor. And I think that's why most mothers who get complications have a very high likelihood of birth asphyxia. Like if you get a malpresentation, it means you have to be transferred like 20 kilometers from the lower level birthing center to the hospital. And sometimes, there's no ambulance. You go on a motorbike, on a motorcycle to reach the hospital, and maybe you're obstructed or something. So some of those are the challenges that eventually lead to poor newborn outcomes. Yeah, I don't know if I've answered to you. Thank you.
Thank you for the question, Hai-Jen. Any other questions from our audience?
I had one.
Yeah, go ahead, Megan.
So I noticed that one of the things that was actually the very lowest was monitoring blood pressure. And I was curious if, because of the prevalence of some of the other causes of maternal mortality, is there a perception that eclampsia and preeclampsia are less common or less important, or is it a shortage of equipment? That stood out to me in your data. Just that it would be impossible to know if hypertensive disorders was associated with asphyxia in your study because the monitoring was so low.
Yes, thank you so much, Megan. It's a very big challenge that we are having. Actually, currently, the hypertensive disorders are number 3 cause of maternal mortality. We are seeing very high rates. We don't know why it has increased, but I don't know whether it's now that we are recognizing it more, or I don't really know, but it's on the increase. It's a threat that the midwives know. It's it will lead to neonatal mortality. It will lead to stillbirths and all that. Some of the reasons why the blood pressure is not taken is there are no devices. At least mothers will get at least one blood pressure reading when they arrive at admission. But yeah, so if it's not taken, then maybe there was no device, or the midwife was overwhelmed at admission. Sometimes the women are admitted after birth. You see that they come very late. Most of them come already in established labor. So if the midwife is busy, she will be pushing before she's even really admitted properly. Yeah, so although this hospital, it's not a very busy hospital really, but the challenges still exist. For example, if they get like a digital blood pressure machine, it works for 3 months, then it's dysfunctional and replacement is hard. It's the same thing with devices for monitoring, for listening to the fetal heart. And yeah, all the other things that are supposed to be taken, like urinalysis, is also not really done. Yeah, so it's a very big challenge, especially the blood pressure one, because preeclampsia and eclampsia are now the third leading cause of mortality for mothers in Uganda. And we've not seen their contribution to newborns, because we just say asphyxia, but asphyxia, intrauterine fetal death, stillbirths must be all due to some of those things. In this study, we tried to collect data on preeclampsia, but we didn't have enough mothers to really make an association. That's why you didn't see it in the obstetric factors.
Yeah. I mean, that's the other thing, is it's not as common as obstructed
Yeah,
labor,
it's not as
as
common,
hemorrhage,
but
as
it's really
infection.
fatal.
Yeah.
Yeah, it's not common, but it's fatal, and yet it can be prevented earlier, even from antenatal.
Mhm. Thank you.
Yes. Yeah, thank you.
Liz, I had one more question. So in your recommendations, which I really appreciated the recommendation slide and thinking about next steps, you noticed this, development of more staff in labor wards. And so really training more nurses and midwives is how I kind of saw that recommendation. So can you tell us a little bit about what's happening in Uganda in regards to training more healthcare staff like nurses and midwives?
Thank you, Michelle. I think training there, we have many midwives actually. The problem is about recruitment because of the financial issues of paying salaries. So I think in Uganda, we really have very well qualified midwives who are, maybe working in small private facilities or doing other work, business people or something like that. So the biggest challenge is really the recruitment. And I think our government is not looking at the burden of care that is there now for the current people, but also, of course, the funds are not adequate to have, the right ratio of health workers to mothers. So currently, I think it is like 1 midwife to 3,000 women in reproductive age, which is really so high, and our birth rate is still high. So in terms of training, we have many levels of midwifery training. We have a certificate level where I think people join after 11 years of secondary education, both primary and secondary, and they get a 2-year program, 2.5-year program, which gives them a qualification to become certificate nurses. We have the diploma programs. We produce so many midwives, and then the degree program, bachelor's in midwifery, is there, and it's also producing many. So I think the issue for Uganda is not the training. It's more about the recruitment into service, and also some of those who have been recruited and they take longer in service tend to, to need updates, maybe the reskilling and the retraining and professional developmental short courses. That's what would be very.
Great. Thank you, Liz.
Yes. Yeah.
Any other questions or comments or conversation pieces from our audience today?
Maybe Michelle, I would also want to ask your opinion in this study. Okay, I have had a lot of a lot of comments, for example, from reviewers, because currently I think in high income countries, to diagnose birth asphyxia, they are looking at pH, and the base excess and that kind of thing, which, yeah, like currently in our hospital, most of the public hospitals, we are not able to do blood gases. And that is actually one of the criticisms I have had. It was very hard to publish this paper because people felt like using the APGAR score is not, it's not accurate. That is true, but that's what we have to use in most of the low-income countries. So I wanted to hear your thoughts and maybe comment on that, or any other person who is in practice. What is your comment?
I mean, I think you can't change the situation, correct? So potentially knowing that they're going to make that criticism and seeing if you can find a reference that where someone did in any setting a correlation between diagnosis based on APGAR scores and diagnosis based on blood gases, and say, so that you can at least say, this is what's available, right? And explain that this is all that is available. And in your discussion, potentially just addressing, when you talk about limitations, you can just say there's a risk of misclassification of the outcome because we had to depend on the APGAR scores. However, research has found, and then be able to cite something that gives an idea of how much you might be off and in what direction. Does using APGAR scores overdiagnose or underdiagnose, or does it go in both directions? But then at least a reviewer knows you're aware of the issue. There's nothing you can do about the issue. And if you're going to get any insight into what's going on in your setting, you have to use APGAR scores.
Okay, all right.
But yeah, if I have a chance, actually, I'll do a quick search and see if anyone has done a correlation study, but that might help. And then you can just address it in your discussion. And then the reviewer can't say, oh, well, they used APGAR scores, because if they read the paper, they know why you used APGAR scores.
Yeah, it's now already published, but that is something that I find challenging. Yeah, yes.
Well, now that yours
so
are published,
much,
you can cite your own work, right?
Yeah.
Yeah, I agree with what Megan said. I mean, I think there's different resources available everywhere, and you're trying to understand what's feasible in Uganda. So really kind of making that point. I think we have a couple of midwifery students on here as well. I don't know if they have anything else to add to this conversation piece. Okay. Well, we'll see if we can find any correlation studies as well for you, Liz. But I want to thank you so much for sharing this work. What a wonderful presentation. Thank you for all the work that you do to support women in Uganda, for research, for supporting, clinicians and students that are also going to continue this work. We really appreciate all that you have done and are doing. I did want to note that Liz is kicking off our Coffee and Conversation series. And so if you're interested in registering to attend future conversations, I just put the link in the chat. Please feel free to share this with students and colleagues. Our next presentation is next week on Tuesday, May 28th at the same time, so 8 a.m. Eastern. And we'll actually be hearing from Hyjin Kim, who is on our conversation today as well, about the lowest low fertility rate in South Korea. So kind of a different topic related to maternal health and how this really does vary by country and region. I think it'll actually be a great presentation to follow this, Liz. We're in the maternal health mindset for the first couple weeks here. But yeah, thank you everyone for coming. We did record this. So I know a few people hopped on late. We will make the recording available if you want to watch that first part for anything you missed. And then we also shared the articles that Liz has published through her work, and we can try to make that available with the recording as well. Thank you so much for joining. Thank you, Liz, for all you do, and hopefully we'll see many of you again next week.
Yeah, you're welcome. Yeah, I would love to hear about the low fertility rate.
It's very, very interesting. I hope you can join us next week, Liz.
Yes, I will.
Okay, wonderful. Thank you, everybody. Bye-bye.
Yeah, thank you. Bye.